Thank you very much. It's my pleasure to round up this session and to talk about the epigenetic therapy in MDS patient today and maybe in the future. Epigenetic therapy is the same like the button to switch off and to switch on the computer. And the human genes also has the same button which we can use to switch off or on the genes and without any influencing the DNA. Two main mechanisms of the epigenetic modification is the DNA methylation and histone modifications. Due to these mechanisms, the genes expression change without changing the DNA sequences. And there are several agents for the epigenetic therapies. DNA methyltransferases inhibitors such as azacitidine and decitabine may be probably the most effective drugs in the MDS patients nowadays. And also the histones inhibitors which are using not only in hematology disorders but also in the treatment of the cancer and other inflammatory disorders. And of course the other drugs like as mRNA and biomarkers and other pathways inhibitors. What is the goal of the epigenetic cancer treatments? It's the attempt to inhibit and reverse the epigenetic modifications, to reactivate the tumor suppressor genes, and to inhibit the enzymes that catalyze the epigenetic modifications. Here you can see the 5 drugs, epigenetic drugs, which are approved by the FDA nowadays. And all these drugs are mainly used in the treatment of the hematological disorders like T-cell lymphoma, MDS, or myelofibrosis. But there are a lot of other drugs which are in the preclinical development, and maybe in the really near future, maybe we can talk about the use of these drugs in the clinical practice too. Shortly, I would like to talk about one of the hypomethylating agent azacitidine mechanism of action. This drug could act in 2 ways. In lower dose, the azacitidine is incorporated into the DNA in the place of the cytosine, and DNA methyltransferase, which is the enzyme causing the methylation of the DNA, is degraded. And in the higher doses, the azacitidine could destroy the cells during the incorporation into the DNA and RNA and to affect directly cytotoxic. The difference between the mechanism of action from azacitidine and other hypomethylating agent like decitabine, you can see here, because the decitabine can only incorporate into DNA, and azacitidine it's also incorporate into RNA, and incorporated into RNA it's blocked the ribosomal activity and protein synthesis. Both drugs can act in the S phase of the cell cycle, incorporating into DNA sequences. Only in this phase they can incorporate into DNA sequences. But azacitidine incorporating into RNA sequences, he could also act without any influence of the cell cycle. We know that methylation is very important for MDS patients because you can see here that 90% of the patient, high-risk MDS patient, has abnormal karyotype, and methylation is statistically higher in the high-risk patient. And this is in the along all chromosomes, and as you can see here, the methylation significantly increase in the high-risk patients, and then it is the complex karyotype. This is the data of the first registration trial of the azacitidine, and the patients were treated with the azacitidine alone and versus the conventional care regimens, including mostly the best supportive care, low-dose RC, and standard chemotherapy. And overall response rate was higher in the azacitidine group versus conventional care regimens. And median overall survival was better in azacitidine group versus the best supportive care and low-dose RC. And from these curves, we see that overall survival was prolonged until the 24 months for the patients in the azacitidine group, and it is more than 9 months longer than comparing with the conventional care of regimen. From the other Italian trial, they achieved the overall survival for their patients median 17 months. And the prognostic factors for this survival was low comorbidity index and the treatment response rate, including the complete remission, partial remission, and hematological improvement. And then if you can see here in the curves that the patients who achieved the remission, the response rate, the overall survival were statistically longer than the patients in the progression. But very important is that the patient with the stable disease also they do better in overall survival, and this is the very encouraging results, because we know that not to stop the treatment if we have the stable disease during the treatment, and because maybe these patients did not meet the response criteria, but they probably reduce their transfusion requirements, and this disease remains stable and do not progress. The side effects are very common in the treatment with the azacitidine, and as you can see here, the hematological side effects as neutropenia and thrombocytopenia is more than 50% for the patient, and it is the 3 and 4 grade. So it is very important to manage carefully during the treatment with this drug, especially as you can see here in the first cycles, because the side effects tend to decrease after the first 2 or 3 cycles, azacitidine cycles. All side effects, also hematological and non-hematological side effects. So it's very important to manage very carefully these side effects in the first cycles, because if we stop the treatment in the beginning of the treatment, so we are risk to lose the effect, to lose the response. Why we should continue the treatment and not to stop? It's shown here because the DNA methylation decreased during the first 3 weeks with the azacitidine treatment, but after the 4 weeks the DNA remethylate again, and this is why we need to continue the treatment, continue the cycle, and only after the several weeks, 8-9 weeks, the DNA methylation level remain stable. From this other registration trial data, we can see that the median cycles to first response in this trial was 2. But if the patients continue to the 6 cycles of the treatment, 91% of the responses are achieved. And 48% of the patients after the 3 cycles, they can improve the initial response. All we know that especially in the high percentage of the blast in MDS patients, it's very important to decrease the tumor burden after the allogenic stem cell transplantation. And here you can see the data from the French trial, and of course what kind of induction chemotherapy to use before the allogenic transplantation is still very conflicted, and here you see that one group of patients, the yellow one, was treated with the azacitidine alone before the allogenic transplantation, and the other group were treated with induction chemotherapy. And overall survival rate after allogenic transplantation was the same for both groups. but we know that to use hypomethylating agents before in the treatment is less problematic, because we can do this in the outpatient department, and there are much less side effects that we can manage. So maybe the azacitidine and or other hypomethylating agents, it could be the option to treat patients before the allogenic stem cell transplantation. Should we continue the azacitidine if the patient received the response, or instead of the allogenic transplantation? And the answer is no, because the response rate, it's up to the 15 months in the patients who have the treatment with the azacitidine. And allogenic stem cell transplantation is still the best option to these patients. And so if the patient has donor, he is fit, quite young, so we have to go to the allogenic stem cell transplantation. And here is also the data from the Italian trial that the patients who were treated with the azacitidine after allogenic stem cell transplantation, these who received the response, complete response, partial response, or hematological improvement, or even the stable disease, significantly better do in overall survival respect these patients who has a progression. And this response was influenced by the low comorbidity index in the diagnosis. Here, 3 years ago was published the meta-analysis of the 11 clinical trials in comparison between the decitabine and azacitidine with the more than 1,300 patients. In these 11 trials, 7 clinical trials with decitabine were included and 4 with azacitidine. In the meta-analysis were included the 4 randomized trials where hypomethylating agents were comparison with the conventional care of regimen. And you can see that there was no difference between azacitidine and decitabine in the complete remission rates, transfusion-independent rates, or hematological toxicity. But azacitidine did better in the partial response, hematological improvement, and overall response rates. And comparing the hypomethylating agent with the conventional care of regimen, best supportive care mostly, azacitidine was superior in the overall survival rate and in the time to transformation to acute myeloid leukemia. And these benefits were not found in the decitabine group. So shortly, if to look in the therapeutic algorithm, maybe I would repeat that if the patient has low comorbidity score, is quite young, and has a donor, so we have to go to the allogenic stem cell transplantation. And the question is what kind of prior chemotherapy we could choose. And if the patient has no donor or is not fit for the stem cell transplantation, we should treat him with the hypomethylating agents. But the question for the future is what to do with the failure, relapse, or progression. So why we need the new hypomethylating agent is written here. It's due to because of the primary or secondary resistance, because these patients' population, the overall survival is less than 6 months. Also, the lack of significant inhibition that results in relatively modest effects on the disease with these drugs.